Good afternoon, everyone. This is really my favorite meeting in neurosurgery. And out of all of the required CME things we do, this non-CME meeting is the only one that's changed my clinical practice since leaving residency. So I genuinely admire the work of many of you who are here. I think it's very important. And I want to tell you today that it's my 5th meeting here, and I feel like an artist in residence at Vegas. So I take requests. And so this study is at the request of Dr. Keller, who asked at my previous presentation, well, what about peritumoral edema? How can you be so sure that the tractography-based resections are sound? So here's my disclosure. I work closely with Synaptive and share some IP, and I have research support from various organizations. And this is the problem, right? That we're very impressed with the geometry of brain fiber tracking. And we can see that the regions which are normal can be very informative. We can see here displacement of the tracts, alteration of the ventricular system, compression of the corticospinal tract, such as there. But in the immediate vicinity of the tumor, it's a mystery. This mystery is the site of the brain-tumor interface. And for a microsurgeon, the brain-tumor interface is really the key to the resection of gliomas. In certain metastases or primary tumors, you can rely on capsular or extracapsular dissections. In glioma, you cannot. So much of the voodoo in medicine, some of the dogma, some of the things which perhaps are panned out by science to not be true, have to do with where to stop the resection. And I'm a firm believer in the awake craniotomy methods described by so many people and by the deep white matter stimulation methods. But if we can have an imaging modality to define those borders, I think that would be superior. So let me preface, as I do every talk, that neurosurgery is anatomy and hemostasis. Now, the hemostasis, flow seal, surgery flow, you guys can choose. But the anatomy is really crucial. And the anatomy could be, well, anything that looks normal, you leave it alone. If it's a bit mushy, you suck it out. If it's bleeding, you burn it. The gap between that kind of surgery to a full understanding of the complex 3D neuroanatomy is huge. And I think imaging is the way to bridge it. I always also show this slide because in many religions believe that humans are undeserving, and so God's revelation of the truth is progressive. You have an early prophet, and then the next one builds on that, and the other one builds on that. And so our understanding of anatomy is progressive, and we've gone from maybe a phrenological kind of view of things, morphology, topography, and spatial relations, to the connectome. And we've had great talks here about connectomics, but really it's tricky in surgery to apply what we know of connectomics in a fashion that is rapid and easily brought to the OR. So in our imaging, the common thread of all things is distortion and deviation from the normal anatomy. And I've based a lot of my quantitative work on comparing the normal hemisphere to the abnormal hemisphere. And I think, we really have to visualize and understand the histological white matter and then compare that with the MRI-generated white matter, unperfected, but perfected in a way that it is applicable in the clinic. In orthopedics, there's this big campaign that says, own the bone, meaning if you're an ortho guy, you should know about osteoporosis and prolea and all of this stuff, not just about the screws. Our burden is a little bit more challenging from a cognitive perspective to own the brain. I would say it's probably more complex than the bone. But I think our duty is to own the brain in a way that we understand not only what we're doing in a tactile way surgically, but some of the things that have been presented here at this meeting, such as what are the histological, pathological effects of edema, what is happening in the microenvironment of the brain-tumor interface. And we know there is great multi-shell MRI out there, and we know that there is fantastic understanding of histopathology, but how do you make that happen in every case, in every clinic all around the country? And one path, I think, is improved imaging. Many of us are comfortable taking out that subdural based just on the CT, but it is really nice information if you get an MRI, even though it is the simplest case in neurosurgery. Having that additional information, to me, is good. It's interesting. It helps my planning. It tells me something about membranes. It tells me if it's an empyema and so many other things. So if I can, I always get an MRI. Well, if I can in a tumor, I always get tractography. And to the extent that it's available in your institutions, I don't see the utility. I don't see the benefit of not using it, because it is like, insisting on watching black and white television when you have a color film. This is a case that I wanted to add because there's been so much ICH talk here, to the lasting shame of the vendors in my area for BrainPath. I amputated a 10 cc syringe and did a transfrontal approach to take this out. But this is a patient who has laryngeal cancer, is a year out from treatment, was doing very well. And so I wanted to, he had a small, looked like a basal ganglia hemorrhagic hypertensive bleed, which quickly expanded. You see the MRI after the expansion here. And so I wanted to take it out, both because I thought he was young and deserved the chance, but also because I wanted pathology in case there was tumor in the hemorrhage. If you look at this scan, the T2 signal demonstrating water in the vicinity of this blood clot, the shortening of the T2 signal here suggests edema, but you don't know in this scan, which is 4 hours after the bleed, to what extent this edema is destructive and indicates necrosis of brain tissue. This was a sort of hyperacute evacuation, and you see postoperatively that a lot of the brain that appears to have almost disappeared is in fact intact and is recoverable. So this is at 2 weeks. A lot of the anatomy, the deep white matter structures just outside the left thalamus, the putamen, the external capsule have reformed, is very aphasic, weak, but actually went home. So I am interested in the edema in and around these lesions because I know that this edema, which is 2 weeks after the initial hemorrhage, this shadow here on CT, in many cases represents necrotic brain tissue, which when resected, if you were to take out that hematoma, which you wouldn't, but if you were, there would be a lot of difficulty with control of bleeding because the surrounding tissue is already necrotic. So we'll change gears to tumors, but it is important to understand that edema is a complex molecular pathology, and the timing of it is important, and what it represents in each entity may be quite different. So in this hemangiopericytoma, it may represent vasogenic edema, displacement of fibers, and perhaps some immune reaction. In a GBM, it may represent infiltration of tumor growth into the surrounding brain parenchyma. In a hemorrhage, it may represent necrosis and ischemia. And so this entity called edema needs and deserves to be visualized and studied. And in each of my talks, I practice a little bit of ancestor worship. And so this is Lyle French, and we think we have so many great and new ideas. I remind you that dexamethasone in the 50s was the use in cerebral edema was discovered in Minnesota with the help of Professor Bock Sun, who went on to be the founder of neurosurgery in Korea. And outside in the hall, there's all this exciting stuff about ultrasonography in the brain. But of course, Dr. French had already experimented with intraoperative ultrasound in the 50s. So all things are old and new again. Well, here is our bleed. And in response to Dr. Keller's request, we toyed with an algorithm that would go from there to there. So here is that, and there is that. So we've added some fiber tracts. And the fiber tracts now are tight around the edema and can tell us that, in fact, in this region here, the water that we see there isn't water, but it's edematous brain, and those fibers can be salvaged. And it allows us to see this very tight corticospinal tract packed around the hematoma, so we don't stick our suction or cautery in there intraoperatively. Here's a reconstruction of using the automated segmentation of just the corticospinal tract before correction and after. So definitely a much richer example of what we can visualize. And then here is an overlay with the SLF and the arcuate. And there it is before and after. Okay, this is based on this fantastic paper, which is worth a careful read for MRI physicists who are inclined. It is the free water estimator using interpolated initialization, or the Fernet protocol. Okay, the Fernet protocol was very carefully and very painfully named by our friend Ragini Varma after this superb Italian drink, which has prevented Argentina from becoming a world power. The consumption is so great. So there is Dr. Varma at her lab. And so we can look forward to maybe a Sazerac protocol in the future. But there is a lot in the name. And what the name indicates is that this estimator takes us from what we all know, in multi-shell MRI acquisitions. If you have a multi-shell 2000, B value of 2000, 64 directions, fiber tracking can be quite easy, and you can achieve a very good estimation of the water. However, using in the clinic single shell MRI is what we wanted. We wanted single shell bicompartmental acquisitions on MRIs that could be available in your regular practice, a 1.5T. And so the study is based on a bicompartmental model that tracks through edema, eliminates free water using the paradigm that assigns a voxel to water or to the diffusivity, the average diffusivity of water, and a tensor to the underlying white matter tissue. So edema is, again, I don't want to do an MRI physics talk or a histophysiology and pathology talk, but we know that cytotoxic edema and ionic edema is a matter of minutes, and vasogenic edema is a matter of hours. We know that the histology and the role of the parasites regulate blood-brain barrier tightness, and that there are all of these extracellular proteins, many who we've never heard of, like the fibronectins and the perlecan and the agrin, which altogether regulate what is the cerebral glymphatic system. The cerebral glymphatic system is the hypothesized pathway of CSF to travel through parenchyma. We can imagine that in this complex system, the gateways that allow passive transmission of water and active transmission of water are very different in bleeding versus acute TBI versus slow-growing tumor versus aggressive infiltrating tumor versus a postoperative tumor where the brain blood barrier has been actively disrupted by surgery. But in all cases, the changes in the hydrostatic pressure gradient plays a key role. So when we operate on these, we decrease ICP, we increase cerebral perfusion, maybe with our thermal damage in surgery, we cause capillary occlusion. So all of our interventions have an active role in vasogenic edema and in perihematomal edema. And also, I believe there is such a thing as postoperative edema, although it's masked by our drugs. My brief summary on that is that the study of cerebral edema is essentially the study of maladaptive ion transport. And the effects of this maladaptive ion transport around pathology can affect the outcome, the technique, the approach, and therefore should be imaged. The Fernet protocol is a way to image this pathology, and we have taken it from the clinical, from the basic lab setting at UPenn to reviewing my case series with the help of these fantastic colleagues, some of whom are in the audience. And this study is being under review currently. And we have basically taken 10 neurosurgeons, 10 complex tumor patients with a variety of lesions and done a survey in which we present a comparative scenario, navigating to the tumor and planning the tumor using normal MRI, conventional tractography, and then our improved or corrected tractography. And we looked at the definition of the lesion, the brain tumor interface, the optimal surgical pathway, and a few other things like if they could guess if a tumor was intrinsic or extrinsic, or if they could guess if the tracts are infiltrated or disrupted or displaced. And this was done via video. So they would watch a presentation in which they had first a presentation of the uncorrected tractography, and then a presentation of, these are videos that I would like to see played, of the corrected tractography. And in the corrected tractography, I don't see it playing, but we see a tremendous amount. The lesion is much tighter, but now there are artifacts, there are false fiber tracts in the necrotic tumor core and in the CSF spaces, but there's certainly a lot more data there than in the previous uncorrected versions. Right, the videos won't play, so we'll just go to this. And so this is a summary of our findings. On the right, you see standard MRI. Adjacent to that, you see standard DTI. And adjacent to that, you see enhanced DTI. I want to point out that the case on the far right is a primary tumor. That's a hemangiopericytoma. The case on the other side is metastasis. Okay, so note that over here, the edema correction in this case adds tracts inside the tumor. And so this is a potential problem. It's, you know, what does that mean? Is the MRI unreliable? And all that means is that Brownian movement is detected in all biological barriers. And so if you have a very organized tumor that has a particular architecture, you basically see tracts that represent the architecture of that tumor inside it. If you have on the other hand, the necrotic center in a GBM like this, obviously the tracts are tight and the information is very carefully contained there. If you have a GBM, such as this case here with perilesional edema, you have very good definition of the brain tumor interface. So this indicates to us that its utility is for resection is somewhat better in primary tumors, in glioma in particular, but you can learn perhaps something about the architecture, the internal architecture of a tumor, even if it is a tumor that then develops false tracts in it during the imaging. And so here is the false negative in standard DTI. And then we did comparisons asking our colleagues if the gray-white matter interface was clear, if there were false tracts in the CSF, if they could see tract reduction, displacement, infiltration, and the answers were true, false, and partially true. And we feel that this dynamic free water, that our free water correction gave everyone a clearer idea of the brain tumor interface, but that the false tracts were distracting. So we asked Synaptive to modify the software, and they have now created, instead of an on-off switch, we have a slider. So you can move the slider, and as you move the slider from 0 to 100, you can add and subtract tracts in the region of the pathology. So you can tighten it to just where you want it. Perhaps if you tighten it more, you start seeing false tracts in the CSF spaces or in the tumor. And so that dynamic correction, I believe, adds a lot of value to the clinical applicability. Do you mind pressing the space bar to see if that video will play? So you see that there is lesion and there is edema around lesion, and you wouldn't be able to tell which is which if you didn't add this information in using the free water correction. So there we are again. Right, so in conclusion, our free water correction algorithm shows perilesional white matter tracts pretty well. It's clinically informative. It gives insights into edematous brain regions. It has false positives that are introduced by this correction process, and it is best applied dynamically by the surgeon manipulating that by hand. It's led to a new software tool, and this is just one more iteration in the path to doing more. I believe in, it's useful to conclude this talk with saying that quantification is important, measuring is important, visualization is important, and we will not get there unless we get these scans. And so I encourage you to use tractography where possible. The algorithm is automated and it doesn't add very much time to each case. And we have an entire range of quantitative things that now measure ventricular volume, tumor volume, resection volume, FA ratios, et cetera, that are all automated in the software. We don't have time to present it today, but in the future, I would like to discuss that here. And I'm open to any questions for the remaining minute.
Any questions for Dr. Koga? Yes, Dr. Chen.
So it's a valid point. In the Fernet algorithm study, we had a series of patients that were 30 subjects, 9 GBMs, 21 normal, who got multi-shell, very high fidelity MRI with B values of 300 at 15 directions and 800 at 30 directions and 2064 directions. And so we then took that data and compared it with 140 that were single shell, and the free water estimations were compared, and we believe that the free water estimations are pretty accurate. I find that when you when you move these parameters, even when you're windowing a CT scan, okay, when you window a CT scan, you can make everything appear and disappear depending on the Hounsfield units that you allow to see on the screen. But we know that the physics of it makes sense. There is X-ray echo against the bone, which is a different density than water. And similarly here, if we window it and we see that the tracts are where they're supposed to be, and they stop at the great white matter interface, and they're not in the CSF spaces, then that makes us feel like they're reasonably anatomically accurate. And that's why the surgeons in the survey were asked, is the white matter interface clear? Are the deep nuclei as you would expect them? It is not a picture that is a perfect picture of the histology, but to assume that human optics is any better is, I believe, also untrue and perhaps naive. You know, what we do with our open eyes, or, you know, yes.
Right. So the question really has to do with the clinical relevance of what you see, right? Yes, you can make a CT of the head disappear by, you know, changing the window, but you look at, and if you bump into that thing and it's there, it's relevant, right?
Correct.
So the question here is, if I were to window the tractography a certain way, and I do a surgery a certain way, what is the assurance that the patients will have a favorable outcome, right? To the extent that if you could window something continuously, I don't know when to stop.
So,
right?
It's a valid point. I think we want to see more of the tracts that could potentially be injured. The perilesional edema washes them out. So the more you can add in, the better, as far as I'm concerned. But if you add beyond, if you add them to the point that it obscures and they're inside the tumor, then you don't know what's tracked. But it allows, it is safer to see more than to see less. This is, I guess, this is my philosophy of it. I'd rather know more rather than look, adjust this black area there and stimulate and hope that I'm right. Dr. Keller. It is a global correction because the spirit of the automated tractography is sort of a democratic tractography that everyone can use. And so it's not regional, it's not selective, it's the entire area. But you can then choose bundles and place rings around the bundle and then see where that bundle connects, maybe in the midbrain or the medulla, and you can see the effects just on one bundle, but the correction is global. You'd have to, you can subtract in the auto-seg, you can remove the parts you don't want to see. So if you just want to see corticospinal tract, you make everything else invisible.